So we're going to get started here pretty soon. We're just going to wait another couple of seconds here for some people to join in. For those of you that are just joining in now, we're just going to wait a couple more seconds before we get started. For those of you that are just joining us now, we're going to get started in just a few moments. Just waiting for a few last people to join in before we get started. All right, so we're going to go ahead and get started. So hello and welcome to everyone that's joining us today. This is our second Simon Searchlight Behavioral Interventions question and answer session. So some of you might have joined us before. We had one of these earlier in the year. For those of you that are new, my name is Curtis Weaver, and I'm a Simon Searchlight Research Assistant, and I will be hosting the session this afternoon. So you should be able to see and hear me on your screen. We won't actually be able to see or hear you, but we're still hoping that this session can be interactive. So we really welcome you to ask questions that you might have in the chat box if you're watching on Facebook, or in the Q&A box if you're using the Zoom link. Please remember, though, that if you're asking a question on Facebook, those are going to be public. So please use as little information that's sort of personal and private to you for the sake of your own privacy. So then here with me today is Dr. Cora Taylor. So Dr. Taylor, as you might remember, is an assistant professor and clinical psychologist at Geisinger Autism and Developmental Medicine Institute in Lewisburg, Pennsylvania, and is a principal investigator for Simon Searchlight. Dr. Taylor completed her graduate training at the University of Tennessee and a research and clinical postdoctoral fellowship at Vanderbilt University. She has expertise in the diagnostic evaluation of children with a range of developmental concerns. At Geisinger, Dr. Taylor conducts research and leads a variety of current research protocols with a focus on characterizing individuals with rare genetic conditions. Dr. Taylor has experience in engaging families and family-based organizations for rare genetic conditions and research through online participation that is offered internationally to patients and families. So Dr. Taylor is going to be answering questions today related to problem behaviors, education, early intervention, diagnosis of autism, sleep, feeding, toileting, and other behavioral interventions. And this is sort of in the context of individuals that have neurodevelopmental disorders, which can include autism, epilepsy, intellectual disability, and more. And then we're also going to be answering a combination of questions that were already submitted ahead of time through email. So we have a ton of those. So thank you to those who have already asked questions. But we're also hoping to answer some questions asked live. So like I said before, that Q&A box or that chat box on Facebook, we'll be taking a peek in those at some point during the webinar too.
Thanks very much, Curtis. I'm really excited to be here today and glad to talk to everybody for a second time. Before we get started, I wanted to talk to everyone a little bit about Simon Searchlight and what we do here at Simon Searchlight. Simon Searchlight is a very ambitious research program, and the goal is to create a large and continually growing database for scientists all around the world to access data on rare genetic and neurological conditions. Our participants come from over 150 different rare genetic disorders that we work with and partner with families, and your insights could hold the clues that we need as scientists to make progress and find answers for the rare genetic condition that impacts you or your child and their development. In order to participate in Simon Searchlight, it's entirely online. You can register online. We take a copy of your genetic lab report. There's a phone call with one of our genetic counselors, and then there's also surveys to complete entirely online. Really, by working in a combination with scientists and patient advocacy groups, as well as families, our goal is to further the knowledge of rare genetic conditions and share those advances back with you.
All right, that's great. So we're going to go ahead now and get started with the questions. So we may not be able to get to all of the questions today, but we're going to do our best. And then some of the medical specific questions related to procedures and treatments that might be outside of Dr. Taylor's expertise aren't going to be covered today. So we are going to go ahead and get started with our very first question. So the first question is sort of about behavior. So this person wants to know, they say, our 7-year-old daughter doesn't know her own strength and hits, kicks, and punches us frequently. She also self-harms, so she hits her head and headbutts, and we are concerned that she's going to hurt somebody else or herself. Sometimes this behavior seems to be because of frustration with communication difficulties, and sometimes it's a sensory disturbance, and sometimes it's for attention. So what do you recommend in these situations?
That's great. And I think you're hitting on a lot of things that you should be thinking about when you have a child who is engaging in some aggressive behaviors and you're concerned about hurting herself or hurting other people. So the first one that I would always ask, and the first one that you touch on, is what's her communication like? We need to be sure that we're giving children or individuals a way to communicate in some way. So if your child has not had an evaluation and they are nonverbal or minimally verbal, with a speech pathologist who specializes in what we call alternative or augmentative communication devices, or AAC, that would be my first step. Giving children a way to communicate that doesn't involve aggression is, we need to be able to provide a replacement. So the aggression is her way of communicating with you right now that I'm upset, I'm frustrated, or something is bothering me, and she's using it in all those different situations. So if we can give her a way to communicate that she can consistently rely on to tell you that she's upset or what she needs in any of those situations, because it also could give her a way to ask for your attention in an appropriate way rather than using aggression in order to communicate with you as a primary way that she's communicating. So that's my first thing, is finding additional strategies that you can use to work with her. In addition, you can try to minimize your attention to it whenever it occurs. So even if it occurs in result as a cause of sensory things that are bothering her, if it is because of frustration, paying too much attention to it in any of those situations could make the behavior worse. Now, on the other hand, we can't not pay attention to behaviors when our child or people around our child might be at risk. So it is very hard to entirely ignore the behavior. But so the way that I talk about it with parents is, first, make your child safe, then ignore it to the extent that you can. So for example, if you have a child who is maybe smacking you, I would try to find a way to block their behavior, so prevent it from happening. And that might be a gentle hold of their arms, or standing behind them so they can't deliberately swipe at you, but trying to pay as little attention to the behavior as possible, which includes limited eye contact, limited actual talking, and trying to engage in that moment, letting them calm down, and then coming back around and engaging. So trying to keep everybody as safe as possible. Again, if a child bites you, that is a common form of aggression that we might see, especially when children who are not communicating. One way to handle that situation without trying to draw too much attention is apply very gentle pressure to the back of the child's head so that their jaw releases, and then you're able to stop the bite without actually trying to engage in any kind of additional back and forth where you're trying to pull or you might be yelling, those sorts of things.
Great. All right, so then we have actually another question that's related to behavior. So this person says, we have a 3.5-year-old son with 16p11.2 deletion syndrome who communicates using sign language. He struggles with choice and is overwhelmed when it comes to picking a story, wearing certain clothes, choosing to play inside or outside, etc. And they usually result in a meltdown. So how can we help stop his suffering from his battle with choices? So usually either choice is perfectly fine, but the idea of picking one is kind of painful for him. So what would you say to that family?
That is something that some toddlers struggle with, even without a developmental condition. And I would support him through choices. So I think there's lots of different ways that you can go about it. It's going to depend specifically on how the child is struggling. So is it that you offer a certain number of choices and he selects a choice and then the meltdown happens and he wants to do a different thing? Or is he voluntarily saying that I would like to engage in this behavior? So limiting the number of choices available at any one given time can be a helpful first step. So keeping him on a schedule, sounds like he probably does pretty well with structure. There are some kids who struggle when there's less structure. And so when there's too many things available, that might be really hard for them to make a choice. They might go back and forth on their choices because they don't want to make the wrong choice. And so I would start by limiting the number of choices. So at any given time in the day, you can support him and help him select an activity, but I would just give him a couple options to choose from. And then if he does get upset and kind of goes back and says he wants the other choice, I think what you can do is show him, perhaps on his schedule, when that second choice is going to be available again. So it's not that because you chose the one choice that this other choice is just no longer an option. You're not going to be able to have this choice for the rest of the day. I would start with, these are the options that are available. Help him pick the option that he wants, that of a limited number, and support him through following through with that option. And then perhaps if you still have some free time, you could then go back and say, okay, now we're going to go back and pick option 2, and show him that he's not necessarily making a choice of which one he wants forever. He's making a choice of which he's going to have in that moment. So keeping him on a schedule, trying to structure the choices, and then trying to allow choice to happen at times when you're prepared to deal with behaviors that might happen, especially when you first start this intervention, where you're going to kind of work with him on dealing with the choice that he picks. That you might want to make sure that you have, your support system around you, anybody else there to help you to kind of coach him through picking that choice, and then giving him like a reward for doing well and a reward for transitioning. That should be the other piece there, is that sometimes with choices, transitioning can be a difficult thing. So like from going inside to outside can be really hard for some kids, and outside to inside can be really hard for some kids. So sometimes the transition itself is also what's playing into it. So supporting them through the actual transition into the behavior. But when they make a choice, I would try to support them to keep that choice, but then show them that they can have the other choice later.
All right, great. So then the next question is a little different. So this is going to be about feeding this time. So this person asks, they say, my 17-year-old daughter, who has the mind of a 6 or 7-year-old, has trouble with night eating. So she often wakes up multiple times at night and eats whatever's in the fridge, but doesn't seem to remember the next morning. So how can we deal with this?
The absolute first thing you need is a referral for neurology. You need to see a sleep specialist. I'm concerned that she's waking up in the morning and not remembering this. It's possible that this could be a sleepwalking behavior, and I absolutely think it's going to be critical at this juncture to consult a sleep specialist who can complete a sleep study with her and identify what's going on in the middle of the night. In the meantime, while you're working on that, I would start locking up the fridge and the cabinets at night so that she does not have access to that during the day. The other question that I have is, do you see any food foraging type behaviors during the day? Because then you could have kind of a dual benefit, but absolutely we need to be locking up all the food at night to the extent that you can, and consult a neurologist who can complete a sleep study to help you figure out what's going on here and the best intervention for her sleep.
Okay, great. So then another question here. So this is sort of behavior based again. So this person says, my 19-year-old son has Kleefstra syndrome and is very high functioning, but has some developmental and social delays. And he's been known to bug girls at school or other organizations he's a part of to go out and be his girlfriend. And it seems like this is through phone calls, emails, text messages, messaging apps. And he sees a behavioral therapist, and we talk about these things, but the compulsion never seems to go away. And then, so this parent is just kind of concerned in this world of technology and social media, how do we make sure that our kids are being safe from themselves and from others?
This is a really important question, because I think you're hitting on a key issue here, which is that sometimes our children's behavior might make them seem less safe to others, and then that makes them actually less safe as well. Whereas the intent necessarily is not bad here. It's not a bad thing for your son to want a girlfriend or to want a relationship or a romantic connection with others. The way he's going about it could be perceived negatively and could put him at some kind of risk, be that legally or in other ways. So thank you so much for this question, because this is an important issue. I'd be curious to hear what the behavior therapist is doing and how they are addressing the behavior. I think it's really important to make sure that we're not addressing incidents, but we're addressing the behavior all the time. So really what I'm talking about here is a social skills curriculum. So, and that means that we are teaching him social skills and reinforcing what is or is not appropriate every day, and not responding to individual incidents when they occur. So there are some different curriculums that is in particular teach children to differentiate what is appropriate versus inappropriate behavior, and trying to understand what is the difference between a stranger an acquaintance, a family member, a friend, and then potentially a romantic partner. So all those different people fall into different buckets, and there's different behaviors that are appropriate with in each of those buckets. And so making sure we outline who is in each bucket, how would we define our relationship with them? So it starts just at the definition level. Is this a stranger or is this a friend? And then what is appropriate? What's an appropriate greeting with a stranger versus a friend? And I think I've talked about this on the last webinar, but it's really important to the extent that you can to start immediately. For those of you on the call who might have younger kids, I would start now with trying to start with understanding the differences in relationships, because sitting on your teacher's lap is really cute when you're 4. It's not cute when you're 17. And so making sure that we try to start early if you can. Now, I know that your son's a little bit older, and so we kind of need to go back and reteach or start teaching those skills now. And that's okay. It doesn't mean that your son is not going to be able to learn those skills, but we just need to make sure that we're doing it very consistently and making sure that there's no ambiguity. So if he were to go up and hug a teacher, I would, even though that might be okay for his teacher, you know, his teacher knows him, she likes him, she thinks it's okay, it might actually be propagating the behavior because he thinks he can just go hug somebody who really is not his family member, who is not his girlfriend, is maybe not somebody that he knows personally very well. So I would set really very strict guidelines, and I would model those guidelines as a parent. So I know some of us are huggers, but people who just, you know, we might meet somebody who knows somebody that we know, and so we feel like maybe we kind of know them, and so we go up and we give them a big hug because it's so nice to meet them. It might not be appropriate to do that in front of your son because he's watching what you do as well. And so whatever rules that we set about appropriate interactions with others, we need to make sure that we're also modeling them ourselves. And I know that that can be really hard and can be a behavior change sort of for the whole family, but I do think it's important, especially if you're seeing some of these behaviors that might seem a little bit risky. So what I would do is go back, just to summarize, go back and teach him about what is or isn't appropriate. Make sure that you're modeling those behaviors. And then in terms of the technology question, that is also really hard. However, I think setting some really firm guidelines and restrictions on his account can be critical, and make sure that you're monitoring his account and what he's actually doing on different accounts. So that can include just general parental controls, which I think over time we're seeing more and more availability of parental controls with the different like tablet and products. Also making sure that social media accounts are you know, that you have access to them if you feel like you need to have access to them so you can monitor what he's doing, and potentially even considering that he is not on it, and especially now when you're teaching these skills, that he is not on his tablet, he is not on Facebook or Instagram or any other social media outlet unless you're kind of with him, coaching him about what is or is not okay to be doing online. That's tough, and it's a hard question, but thank you for asking it. I think it's important.
Yeah, that was a really great question. Also a very modern question with social media, since that's not the kind of thing that would have been around, say, 15, 20 years ago. So the next question we have here is from somebody that says, my son is 8 years old and has autism spectrum disorder, ADHD, along with a genetic change in the ASH1L gene. So he struggles with focus and paying attention, especially around electronics. So another electronic-based question. In fact, he doesn't talk to strangers, but when strangers have an electronic device in their hands, he has no problem approaching them. So how can we work on improving his attention span and reinforcing the fact that he shouldn't approach strangers? As soon as he sees an interesting item, he forgets all that he's learned.
I think this is a really similar question to the one we just answered, so this is great. And I think, again, the first thing is to address the behavior, not individual incidents. So I would not wait until he approaches a stranger inappropriately for me to like talk to him and remind him and coach him about what is or is not okay behavior. And again, teaching him what different buckets people might fall into. And I think I forgot to mention on the last the last question, that one way we can start teaching children like what is or isn't appropriate is they also need to not only be able to identify what are the different buckets, what's a stranger, what's a friend, but also who falls into which one. And you can do that really through pictures. So you could potentially download pictures of people that you know that the child does not know, be that like celebrities or people you see on the news, as well as family members, as well as a picture of the teacher, as well as people that are friends, and help them identify, okay, what category is this person in? Is this person a stranger? Or is this person a friend? Or is this person a family member? Acquaintance is a little bit harder. That's more of an advanced skill. So you can even kind of lump stranger and acquaintance together just to make it a little bit more clear for the child that typically we would interact with a stranger in a similar way as we would interact with an acquaintance. But I would start with the same thing. We're understanding who is in which sort of social bucket and help them understand who goes into that bucket and what behaviors are or are not appropriate. So for strangers, I would definitely teach that approaching a stranger is not appropriate. And again, not waiting for an incident to happen, but making sure that this is just part of the curriculum. It could even be built into their individualized education plan, which is something that we have here in the US for individuals who are receiving any kind of special education services. But for many of our children, these kind of social goals are really important in addition to speech goals, reading goals, writing goals, math goals. Social goals can fall by the wayside sometimes unless parents really advocate for them.
Great. So then here we're going to actually answer a question that was asked today during the session. So somebody asked, they said, my 5-year-old son is starting to show a lot of ritualistic behavior. So the paths he chooses, the routine, and though he uses communication cards, he screams a lot when happy or frustrated. So for example, if he gets home and wants to have dinner, he might not even be hungry. And it stops him. It only stops when he gets food. If he's tired, it gets worse. I've tried to ignore his behavior. I've tried to talk to him, put him in a playroom, but haven't made any progress. So what advice would you share?
Well, I'm glad that he's using some kind of a communication system. It sounds like maybe you're using like picture cards for him to get what he might want. That's a great first step. Importantly, when we teach children picture cards, it is important to make sure that we honor what they ask us for, especially for our really early communicators, unless it's really something that's not available. So if he's just started using the communication cards, I would be somewhat more flexible with him about honoring what he's asked me for, because we want him to teach him that communication cards work. If he's at that stage where he knows communication cards work, then you're absolutely right. It is appropriate to start teaching him that no is sometimes the answer. And so if he is asking for dinner, it might be that he just needs to know when it is available. And so just like I mentioned kind of with an earlier question about making choices, a lot of times the children, if he's communicating with picture cards with us, he probably is also having a hard time understanding what we say to him. So I would not necessarily encourage you to try to reason with him, because he probably doesn't necessarily, assuming that his communication level and his language level are similar, which for many children that's true. Reasoning with him will probably make it worse. In that if we start giving a lot of attention and start talking a lot to a child who wants one thing, but we're not providing it, that can be really, really frustrating. So I would communicate to him in like one word. If he's putting 2 communication cards together, you can do 2 words, and you can potentially say, not now, stop, later, but being very, very, very calm about it in your demeanor, and potentially trying to distract him. If you're using a schedule, which if he's using communication cards, I wonder if maybe his school might be using a schedule. So if we're using a lot of visuals to communicate, sometimes school is also using a lot of visuals to communicate back to him, as opposed to just communicating to him with words. So I would think about including visuals in the way that you communicate with him as well. So if you have a schedule, and he might have like an after school routine, and we can orient him when he comes home, this is your after school routine. This can be done through line drawings. So if he has communication cards, they might be line drawings. Sometimes we see communication cards that are pictures. So think about, what do you want his after school schedule to be? So he's going to come home from school. Does he get some free time first? And what would that free time look like? Maybe it's, you're going to suggest that he might play with blocks. So I would have a picture of his blocks, and you can bring him home, show him his schedule, blocks, then bath, then dinner, or blocks, then dinner, then bath. It's hard to know like whether or not he's hungry. He might, I don't know if is he giving you a hungry card or a dinner card to let you know that, but potentially giving him like a small snack when he comes home. And so you could have a card that's like snack time, then playtime, then dinner time. So trying to create a lot of structure in his day and communicate with him not only with words, but also with pictures too. And if there are strategies that are working at school, like a schedule, like I'm suggesting, if that does work for him, I would try to implement it at home, and it can help with his evening or after school routine and his morning routine as well. I understand that sometimes these things are really difficult and we will run into a lot of really hard behaviors. But I would, and when you go kind of down a route of I'm going to ignore the behavior, the best thing you can do for yourself is you kind of have to commit to that decision. Because if you're going to pick a battle with a child and decide that I'm going to decide that this activity or this thing that the child wants is not available, the minute you give in, what you've taught your child is this is how long it takes for me to scream until mom gives in. So what we find sometimes is that if that bar for the child is, the child will scream for 15 minutes, but our patience is only 10 minutes long, then the child will learn that they can outlast you. And so if you make the commitment that you're going to say, no, not available right now, show the child when it's available. And if he does get upset, you do have to stick with it until he calms down. Otherwise, you're just increasing his tolerance to scream longer. And it is really hard. So I would encourage you as well, if you have the support system, to have somebody with you when that happens to coach you and keep encouraging you, because it is hard. It's hard to hear your child cry, and you want to make your child happy, and you want to give them, what they want. And you also know that you have a child with special needs, and that's a struggle as well, to make sure to feel like you're providing everything that they want. So having a coach as well can sometimes be really helpful, because these are hard situations to have to go through as a parent.
All right, so then we're going to shift gears a little bit with this next question. So we're kind of going to cover the topic of toileting a little bit. So this person asks, or they say, my almost 14-year-old daughter has OCNDS, which for those that don't know is Oker-Chung neurodevelopmental syndrome, and has achieved bladder and bowel control, but still has some challenges to overcome. So which bathroom to use? So she'll go at home, malls and restaurants, but she won't go at school or at a grandparent's house, which is more familiar with her or familiar to her. And then also difficulty getting her to use the toilet when it interrupts an activity that she enjoys. So what suggestions do you have there?
Great. That's a great question. So there are a lot of kids who have struggled potentially with toilet training who kind of end up in a similar scenario as what you're describing now. And some of our children really struggle with change. And so, different toilets, different environments can be hard. So my first question is there something about school or grandparents that is not just about the toilet itself, but about the environment? So sometimes like schools will have loud hand dryers, although I'm not immediately suspicious of that because she'll go at malls. So there's probably loud hand dryers at the mall. In terms of school, I guess my first question is, will she even go into the bathroom? Will she sit on the potty? What will she do at school? Schools can put toileting goals into an individualized education plan. When kids are struggling with toilet training, and if that is carrying over to the school environment, I would at least start with the school taking her on scheduled sits. So sits on the toilet. So even if she doesn't have a success, just getting to the point where she will she will enter the bathroom, she will sit on the potty, even if she doesn't have a success, is a place to start. Sometimes schools might be, I'd be curious if she's like wearing diapers at schools full time, or if she's wearing a pull-up at school full time. I've talked a little bit in the past about something called diaper fading, where, if you put a diaper or a pull-up on a child who is just refusing to go unless they have a diaper or pull-up on, one way to help with that behavior is to cut a hole in the bottom and require that the child sit on the potty and use the potty in the bathroom, but everything kind of goes in the toilet, even though they still have the pull-up on. So we're kind of slowly transitioning. In terms of grandparents' house, my first question is, how often do they go to the grandparents' house? If it's something that you really want to work on, I would potentially think about taking them there every day. And having them do just at least practice sits on the potty. If it's something where they only go there, once every other week, it could be that the environment is just so new and it's confusing, or they don't like the potty, or something's different about the potty. So there's when you really think about it, there's lots of things that can be different. There can, like, some of us have like fuzzy toilet seat covers or fuzzy things underneath their feet that we might not like. And sometimes it's cold tile, and sometimes the toilet seat is cushy, and sometimes it's firm. And there are lots of different variables that might be playing in here. So I would think about maybe what's different between the toilets and just starting with practice sits. I know that sounds really like what we do very early on in potty training, but starting with just those practices, getting her really comfortable and used to those new environments, and engaging the school to put toileting goals into her plan.
Great. So then we have another toileting question here. So this person says, our daughter has MED13L, so it's great. We're getting a lot of different genetic change representation. So our daughter has MED13L as well as autism spectrum disorder and intellectual disability, and has been working on toileting at her ABA therapists. They are using a set schedule every 30 minutes with time sitting, and does very well, understanding when to go when she's on the toilet. Yep, I read that right. However, she struggles to stay dry between sessions and doesn't have a sense of when she's had an accident. So what's that next step in that situation?
Great question. So what her ABA therapist is working on with the scheduled sits is great. I think that what I would add to the program is have the school do it as well if she's going to a school, and also start thinking about doing this at home and going on scheduled breaks. You could potentially even increase the interval if you're at home, and like give her a lot of juice or a lot of water. So you're like increasing the chances that she understands what that feeling is and starts to associate it. I would also take her on a bathroom trip and have her sit on the potty every time she has an accident. So in addition to having her be successful because we're taking her on timed bathroom breaks, we're also letting her know that when you feel this sensation, you're going to need to go sit on the potty either way. So that would be the addition that I would add. You could look up what is called the rapid method of toilet training, which involves a lot of scheduled sits. And I'm glad that she's having success with the time sits and understands what she needs to do. That usually is the step that comes first. And then we get to the point where she is able, or a child is able to recognize when they need to go. So I encourage you to think about, you're just at the early developmental step. What you need to do is keep doing what you're doing, maybe even increase it to happening at a home and at school as well. Also take her on bathroom trips when she has an accident, and give it a little bit more time.
All right, and then it looks like we have one more toileting question here. So we're really struggling with toiletings and BMs. So our child is 9 with intellectual disability, very impulsive but verbal. She gets incredibly anxious and refuses to poop on the toilet. She has been toilet trained to pee for years without having any issues, but she will hold her bowel movements until she goes in a diaper. When we have tried taking away the pull-up option, she has held it in and becomes very constipated. So we've tried different toilet seats and things like that. So do you have any recommendations on helping with potty training?
Yeah, that's a great question. Yep, and your training for urine usually, in most cases, will come first, and then we'll see training for bowel movements come second. The first thing that jumps out at me is that there's been concern for constipation. So kids who have a history of constipation or any issues with constipation sometimes will struggle more with toilet training because there's a history of bowel movements being really painful. So if you haven't consulted a pediatric gastroenterologist, that would be one of my first steps, just to make sure that there's nothing else going on that needs to be addressed from a medical standpoint if you haven't already done that step. Sometimes when kids get constipated, they need to have like a clean out, or maybe some medication options to make sure that she doesn't get constipated might be indicated. And I would want you to talk to a pediatric gastroenterologist about that as a first step. In making sure that we're ruling out all the medical issues before we go down the route of having the bowel movements. Diaper fading could potentially also be helpful in this situation. Some of our kids struggle again with change, and so the change from having bowel movements on the potty to having bowel movements in a pull-up can be difficult for some kids. So I would start with, what will she do? So having will she have a bowel movement in the pull-up, but make sure it's in the bathroom, or having a bowel movement while sitting on the potty. If your child is short, I would make sure that you're putting a stool so that there's somewhere on the ground for her to put her feet. And then also engaging in what we call diaper dumping and making sure that to the extent that he or she is able, having them help clean up afterwards, including taking care of the pull-up, wiping, all those things, dumping the bowel movement into the potty and flushing the toilet as well to try to reinforce that that's where that goes. But your first step, if you haven't done it, is with a pediatric GI specialist.
All right, then we're going to shift gears again, and we're going to talk a little bit about some supports and resources. So this person says that my foster adopted son is 16 and has a 16p11.2 duplication and was finally diagnosed with ASD. So he's been in residential treatment facilities for the last 3 years. What is the difference between a medical diagnosis of autism versus an educational diagnosis? And then continuing on, my son also has ADHD, RAD, DMDD, ODD, among other things. So how can we make sure that he's getting the best supports?
That's a great question. So I'll start with the first question, which is what's the difference between an educational diagnosis and a medical diagnosis? There are some nuances here. So I'll try to give you a broad answer and then maybe tell you about some of the nuances, but it's also important, I think, to talk to the school a little bit about this, or whoever gave him his autism diagnosis might be able to help you differentiate. So a medical diagnosis comes from somebody who is a licensed medical professional or health service provider. So it could be somebody who's an MD, a DO, like a neurologist or a developmental pediatrician. And then there are also PhD psychologists who might give autism diagnosis. If they're licensed as a psychologist with their state, they would be able to give an autism medical diagnosis. If the school psychologist gave him the diagnosis, she may or may not have been able to also give him a medical diagnosis. Some school psychologists are licensed by the state as licensed psychologists. Some school psychologists are licensed as just school psychologists, but not licensed psychologists. It's a nuance, but there's a slight difference there. And so some school psychologists will not be able to give both a medical and an educational diagnosis. They might only give the educational diagnosis, whereas some school psychologists in certain states might be able to provide both. Really what it comes down to is the school could designate that they feel that the child has autism, even though that maybe a medical professional has not done that. Not all schools will do that. Many schools will require that there is a medical diagnosis present in order to serve a child as a child with autism. And that diagnosis just goes in their individualized education plan or IEP, and that's the categories that children fall into for services are actually federally mandated. So one is autism, but also like learning disability and hearing impairment are all educational diagnoses that help children get services. And so some children with an educational diagnosis may not receive a medical diagnosis. For the purposes of getting services as an adult, so for example, an autism waiver program or other vocational services, it might be important to think about getting a medical diagnosis if you want to get that as well, to make sure that they have your child has access to all the services that they might be eligible for. In terms of the second question that you asked, in terms of how can we make sure they're getting the best support, I would really try to take a multidisciplinary approach. And by that, I just mean engaging all professionals that might be relevant. So based on what you're saying, your child has a lot of different diagnoses. And so I would be sure absolutely a psychologist needs to be involved in their care, potentially also a psychiatrist if they need some medication management. Often residential facilities will have a psychiatrist on staff who can help. The school definitely needs to be involved. His pediatrician, or if you have a developmental pediatrician might be a really important piece of the team here if you have not already engaged a local or somewhat local developmental pediatrician. And all these people need to talk to each other. So coordinating everybody who's involved in the care. I would be curious as well, kind of what the residential program looks like in terms of how often you're meeting. Often the residential programs for younger kids will involve the school system. So making sure that all of the points of care here are all talking to each other is really a key critical piece.
All right, great. So then here we have a question. Somebody is they say, my 9-year-old son has OCNDS, ASD, and anxiety, and has trouble with avoidance refusal around school. So he seems to be in fear panic mode about going to school. The school seems to view it more as defiance that rewards and punishments can fix. But what are your thoughts about viewing it through the lens of a neurodevelopmental disorder?
That's a great question. So, the first thing I would talk about with your child's school is absolutely there's. I mean, if your child has a neurodevelopmental condition, we can't ignore that as a piece of the puzzle that's going on. But the important thing for anxiety. Is really just helping coach through the situation. I don't know that a punishment I would not think would be helpful here, because if he gets to school and he gets upset and he gets punished for getting upset, that's not going to be helpful. Especially in terms of making him less anxious about going to school. And I'd be curious as well too, do you feel like there's a separation anxiety component going on here, or is there more about what's going on in school? I would potentially if the school has a behavior specialist on hand who could come in and kind of see what's going on. Are there certain times of the day that he seems to be upset? Is it just when you drop him off? Letting children avoid school does tend to make it worse. So if he gets really upset and he's allowed to be picked up and come home, usually we'll see that anxiety or that reaction will get worse. And then the other important thing to consider, especially if we think about this from a neurodevelopmental perspective, but sometimes kids strongly dislike school if the work is not where it should be. So for example, if your child is 8 years old, but they are currently at a neurodevelopmental level of a child who's closer to about 4, they likely it's not appropriate to present them with grade level work. So we will see some school refusal and frustration and getting really upset and potentially even appearing anxious when at school the work does not match where your child is. So that's another key piece to consider, especially from a neurodevelopmental perspective, that they're providing him with the appropriate instruction at school when he gets there. I think this is a complicated issue that probably warrants a meeting with the school to see exactly what is happening. When is it happening? Are there certain teachers that are triggers? Or is it certain support staff where it seems to happen more? Or is it more of a drop-off time? And how long does it take him to recover?
All right, so then the next question is sort of going back to behavior. So my 8-year-old daughter has Shaw-Gibbs syndrome, and growing up, she has more and more problems managing her emotions, both positive and negative. What can we do to help handle her tantrums? Usually there isn't anything I can do until she starts to calm down on her own.
Yeah, and the children until they get a little bit older tend to have a hard time identifying when they're getting a little bit escalated, and that can be positive or negative. So when things are getting hard, they might not realize, where I as an adult kind of recognize oh, my chest is feeling a little bit tight or feeling a little shaky, maybe I'm feeling a little nervous, and then I can use some strategies to calm myself down or recognize what's making me anxious and remove myself from that situation. Our younger children with developmental disabilities in particular may have a hard time with that step one. So they might not realize that they're upset or anxious until it's kind of too far gone, and then they have to bring themselves down, but they're already so escalated that it takes a long time to get to that point. And that you're right, at that point, similar to what I mentioned earlier, it's very difficult to reason with somebody who is already kind of off the charts. So your only strategy at that point, if you can't help her catch it early, is probably to let her start bringing herself down. Once she gets to a point where you can kind of have a conversation with her, then you probably have a little bit more power. That said, in terms of strategies, I would start thinking as a parent, because we have to kind of teach that skill. We have to teach her what I described earlier, which is to recognize that maybe things are getting a little bit escalated and practice some calming strategies. So we have to teach her the calming strategies themselves, which you can teach her now, especially when she gets too escalated, when she starts to calm back down. You might have some strategies for her, like deep breathing or going to a quiet space or other activities that might help her calm. But we also start to look for signs where you realize as mom or as dad or as her caregiver that she's getting escalated. And I would intervene at that moment rather than letting it get to a really significant point before you help her try to start bringing them down. bringing her emotions down. And it might require a fair amount of coaching on your part, especially when you first start. But the goal is always then to take those skills that we've taught her and teach her to do it more independently. Although at the beginning, it might require that you're intervening quite a bit, but with a goal to kind of back yourself out and let her manage her emotions a little bit better on her own. If you're continuing, however, to see these like really big emotional reactions, potentially things that sound like if their mood swing, like it might be worth engaging with just psychiatry just to make sure there's nothing going on from a mood perspective that may be worth addressing.
All right, so then the next question here is from somebody that says, my 17-year-old has STX-BP1. Again, we're having great genetic change representation today. So they have STX-BP1 as well as autism spectrum disorder. We deal with a lot of behavioral issues related to noise. So she loves certain things to be loud, like music, but really hates the doors shutting, dishes being put away, or even like the cat crying. An audiologist confirmed her hearing is fine, and I was told that headphones could be really helpful. So what advice could you provide for getting her to tolerate some of these like distracting noises?
I think headphones to start with is a great first step. I wouldn't end at headphones and just say we're going to put headphones on and just consider the problem solved. But headphones is a good first step because we do need to help her learn how to tolerate these different noises potentially, but maybe in kind of a gradual way. So psychologists or behavior analysts often call this systematic desensitization, which is that if she's really upset by the sound of like closing doors and dishes right now, it's an unreasonable goal to think that she's going to be fine with it tomorrow. So what we need to do is provide some interim steps where we can make her more successful. So if you think about, there are some headphones out there that are, noise canceling, but then you also kind of have you also just have earmuffs, which are not noise canceling, and don't provide as much sound protection. So I think it depends on how much sound protection she needs now, and then you can kind of step down from there. So if you tried headphones, how much could she tolerate? Could she be in the room with the dishes? And also I would think about how much this is disrupting her day right now, to what extent we need to have her be okay with the sound of dishes. But having her potentially in the same room with the dishes with the headphones on, would that be okay? And kind of just going from there and stepping back so that she can handle more sounds.
Right, so then this next question I think is a really great question. So what can we do when there's no one in our area who knows about a particular genetic change? Research is great, but without help and support, it can make you feel kind of hopeless.
Yeah, that's a really good question. And thank you for asking it, because that can be really hard to find somebody who specializes in your specific genetic condition. That said, there are specialists, there may be specialists who do. I would think about reaching out to your family support group if you have one for your specific genetic condition, to get an idea of what providers they've used in the past and who's been sensitive. But also a lot of times it's about educating our providers and telling them about the genetic change too. So kind of at a grassroots level, letting your provider know what you know about your child and their genetic change. There are booklets available. If your genetic change is on our website, you can find the gene change that's associated with your genetic change and find the resources that we have. Now, there are some ultra rare genetic conditions where there is less information, but I think that's an important part of being involved in research here, is we want to try to learn more so that we can do better about educating providers about the genetic change. In addition, if you're not linked up with a geneticist or a genetic counselor that you're checking in with on a regular basis, I would encourage you to do that. The role of a geneticist or a genetic counselor is to be the up-to-date person about genetic conditions. So if you're not talking to a genetic counselor on an annual basis, or geneticist on really a yearly basis or every couple years, to get an update about what new things do we know about this genetic condition, I would strongly encourage you to do that.
All right, great. So then this next question, how do you determine the type of autism a child has? And how can you learn to understand a child who is nonverbal? So that's sort of a two-parter there.
That's a great question. Quite a few years ago now, we used to differentiate between types of autism. So we had autistic disorder was one type of autism. There was Asperger's syndrome, and then there was this word salad called pervasive developmental disorder, not otherwise specified, which you would sometimes hear called PDD-NOS. That was also kind of a type of autism. Through some research and some changes to what's called the Diagnostic and Statistical Manual, which is a handbook that psychiatrists and developmental specialists might use to diagnose autism and other psychiatric or neurodevelopmental conditions, made a bit of a change and kind of collapsed those all under what we call autism spectrum disorder. And now we don't differentiate necessarily between subtypes, but there is a differentiation in terms of what we call level of support, recognizing that some individuals might be what we refer to as higher functioning and need relatively less support, whereas other individuals might need more support. And typically you'll find that your psychologist or developmental pediatrician will rank that as level 1, meaning requiring less support, and then all the way to more like a level 3, which we would say is requiring very substantial support. And a lot of that is about how you as a caregiver are helping to support having their wants and needs met. So for example, a child who is nonverbal, as you mentioned, who does not have a way to communicate, likely needs more support day to day to make sure that their wants and needs are met versus a child who's very verbal, just as an example. And then in terms of supporting individuals who are nonverbal, I think I mentioned earlier, but we definitely want them to have an evaluation for alternative and augmentative communication devices, which could include iPads. It could include the picture cards that we've talked a little bit about over the course of the session today, and having that as a strategy for them to communicate.
All right, and then we have another question related to autism. So we have a 5-year-old who is diagnosed with autism. He has all the characteristics, including late speech, toileting, lining things up, always wanting to have things certain ways, meltdowns, echolalia, etc. And I've been doing every food intervention that I've come across for the last 18 months, and now his autism is hardly noticeable. Are food interventions really that helpful, or is it just a coincidence? His progress started after going vegan in July, and he went gluten-free as well.
So the answer to that question is that we do not have enough high quality research studies to say one way or the other. We certainly have parents anecdotally who have told me that they tried this one diet and it worked and it seemed to solve all the problems. But we do not have any good evidence to recommend any specific diet in particular for autism. You are correct that it could be a coincidence. When we have kind of, oftentimes kids, will make progress, and there might be a point in time where their progress kind of speeds up, and it's going to be hard. We're not going to be able to go back in time and identify whether or not the food was the critical piece there. We definitely need more controlled research trials in order to identify whether or not any of these interventions are helpful. All the different interventions are usually based on a bit of a theory as to the underlying cause of autism. So gluten, casein-free diets are something we hear very commonly. Gut health is something that we hear very commonly. We do know that autism is a brain-based disorder, and that a lot of our children's brains were affected very, very early in their development. So the idea of changing food, it is likely not necessarily the cause based on what we do understand about autism spectrum disorders, but we really don't know for sure other than hearing sometimes anecdotal evidence that they work. And then we also do hear anecdotal evidence from other parents that felt like it wasn't effective. So unfortunately, I don't have a firm answer for you on that.
So then a little bit on a similar vein here with feeding. What would you recommend for kids who have a hard time focusing on mealtime activities, such as using cutlery to eat, but not looking at their plate?
That's a great question. So first I would start about thinking about how can you build in a little bit more structure. So depending on the age of your child, are they sitting in like a high chair, which is a way to provide kind of physical structure, for a child, or sitting in some kind of a chair that helps them sort of focus on what am I supposed to be doing right now. So it even could be like an activity chair if you have a child who's a little bit older. And in terms of using cutlery, I would like to know kind of where they are right now. So are they, what steps are they doing? Are they loading the spoon or the fork by themselves, like stabbing or scooping and bringing it into their mouth, or what steps in that are they doing? And I would start by having them do just the last step. So you might load it for them and just have them bring it to their mouth. And if they're able to do that, then start coaching them to scoop, but build in some structure so that they know what their activity is. Try to limit distractions of other activities. And again, potentially one way to do that is like an activity chair, and then kind of work backwards where they just start with bringing bites to their mouth, and then you add on the other skills as they get better.
All right, and I think we're wrapping up here shortly, so we might have time for just one or two more questions. So, how to select the school path for a child with a major speech delay? Is it helpful to postpone the school start for a year and maybe redo preschool to help speech develop? Also, the parents are considering a regular school class with inclusion or a separate smaller class with other children with various disorders.
Okay, that's a great question. And it's hard without specifically meeting your child to tell you which path might be correct. But his school professionals are going to know him best and hopefully will be able to help best advise. So holding kids back is a reasonable thing to consider. And it's also reasonable to consider kind of pushing a child forward depending on where their skill is. So one question I would have is, okay, they might have a speech delay, but do they have any way to communicate at all, which might be a little bit of a factor in the decision. Also, what's their maturity level compared to other peers? What friendships have they formed? Who's going to be in the next class? And at what level of support do they need? So if your child is not going to be successful, if they do not have a one-on-one or a two-on-one of some sort, then I would potentially select the smaller class versus the regular classroom, unless you could have a paraprofessional with your child. So I think we would want to go through what are all the different iterations of what might be possible here, what supports are already built in, what supports are available that we could add, and go from there.
All right, and then I think this is another kind of similar themed question for our very last question. So how can you help someone who is nonverbal with communication?
Great, and this has been weaved throughout. Communication is so important. And I think when we're talking about behavior, we always need to remember that a lot of the behaviors that our children are showing to us, even if they're behaviors that we would not prefer, like hitting or biting or scratching, behaviors are the way that our children communicate with us. And what we want to teach them to do is communicate with us in a way that is easily understandable by others, so not just us, where we might be able to anticipate what their needs are, but also doesn't involve any behaviors that might be harmful to themselves or harmful to others. And the method to do that is alternative or augmentative communication devices. We've talked about a ton of them today. We had a child earlier we were talking about who's using sign language. That's one alternative communication device. So we might teach our children to sign for more, so all done, to help them communicate with us. We also might have children who use tablet devices or picture exchange devices. There are a variety of both what we would call low-tech options and high-tech options like an iPad, and finding a speech therapist who can specialize or do an AAC evaluation for your child is a great first step.
Fantastic. All right. So thank you everybody who's attended today. This has been great, and all the questions that you guys have been asking have been really, fantastic. I feel like I've learned a ton just from listening to Dr. Taylor speak today. So as we're sort of signing off, if you want to learn more about Simon Searchlight, our registry, and how you can join, please visit our website at simonsearchlight.org. And you can always email us with any questions you might have. And our email is coordinator@simonsearchlight.org. So once again, thank you guys so much for attending today. And we hope to do this again sometime soon.